Okay, I'm admitting.
Good evening. Hi, everyone. I am Irvine City Council member Melissa Fox. I'm also a candidate for the 68th Assembly District. The 68th Assembly District includes all of Tustin, Lake Forest, Villa Park, and the city of Orange, as well as much of Irvine and parts of Anaheim and the Canyons. Thank you for joining us in our virtual town hall with Dr. Ebony Jade Hilton. Our topic tonight is exposing inequalities during COVID-19. Black and brown communities in the United States are being hit much harder by the COVID-19 virus than white communities, and communities of color have had a higher infection rate and a higher fatality rate. People of color are also overrepresented on the front lines, from frontline healthcare professionals like Dr. Hilton to essential factory workers and retail employees. We're fortunate to have Dr. Hilton here tonight from Charlottesville, Virginia. She's going to talk about these issues, specifically what the COVID-19 pandemic has exposed about the underlying racial and economic disparities in our country, and importantly, what we can and must do about it. Thank you, Dr. Hilton, for joining us.
Yes, thank you all for having me.
Dr. Ebony Jade Hilton received her medical degree from the Medical University of South Carolina in 2008. And she made history in 2013 when she became the hospital's first African-American female anesthesiologist since its founding in 1824. Dr. Hilton is currently Associate Professor of Anesthesiology and Critical Care Medicine at the University of Virginia Medical School. The medical director at Goodstock Consulting, and a nationally recognized expert on how institutional racism has led to more severe impacts from communities of color from diseases such as COVID-19. Thank you so much for coming on with us today, Dr. Hilton. We were really excited to see you on other media. You're very active on social media, on regular media, and you've really had a way of explaining exactly how without losing us in some of the arguments, exactly how communities of color have been disparately affected. So I hope that you can give us a little introduction tonight and tell us about what you've been seeing.
Yeah, well, I thank you again for having me. This is actually kind of cool to think about talking coast to coast. But we know from COVID-19, what it's kind of uncovered is that racial health disparities exist regardless if you're in the north, south, east, or west. And that with COVID-19, one thing I keep telling people is that racial health disparities did not start with COVID-19 and it won't end with COVID-19, that there is systemic racism in place that kind of feed into all the social determinants of health. And just so we can get that out of the way, what does that mean? So when we're talking about social determinants of health, we know that you're only as healthy as all the factors that play into health. So whether that's when we're dealing with nutrition, for instance, when we talk about COVID-19 and the populations that it impacts, we say those were pre-existing comorbidities. And so what tailors or what pushes someone to have these comorbidities? So if we're talking about hypertension, diabetes, for instance, we can't talk about diabetes and obesity without dealing with food deserts or food apartheids, basically the way neighborhoods are literally structured and whether or not they're gonna have a healthy eatery within walking distance, or if that community has to rely on the fast food chains or the corner stores to get their source of nutrition. We can't talk about the impact that COVID-19 has on those with respiratory diseases, right, of asthma and chronic bronchitis, without talking about the industrialization of certain zip codes. Literally within zip codes, you can have microcosms of where we have these industries placed closer to these individuals and those individuals, and how does that pollution of the air and water impact whether or not our children are developing asthma at higher rates. You can't even talk about, particularly with COVID-19, we hear about these vulnerable populations, of which we mentioned nursing homes, and we mentioned also prisons, for instance, right? you can't talk about prisons without talking about policing in certain communities and the higher jail sentencings that are given to certain groups of people, whether that's Black and brown people or those lower socioeconomic status patients. And so there's a number of different factors that are playing into whether or not someone literally lives or dies at the hand of COVID-19 that are not traditionally thought of as being linked to health. And so that's one of the things that those systemic practices have been around as far back as the founding of America, but truly in the 1930s with redlining, we really saw a big push of defining where certain groups of populations could live. And we're now seeing very bluntly the impact of what it causes. So what we know in the United States right now, for every 2,000 Black people that were alive in January, one of them have died at this point. And for every 3,000 Hispanics, Hispanic Americans that were alive in January, one has died. And so these are great numbers. And the truth of the matter is that we honestly don't even know if that's the true totality of who has died. We know we don't have testing in place. We know we had a nearly 14-week delay in the testing from the time that we had cases known in the United States and the ramping up of our testing capabilities. So we know many people died without us knowing if they had COVID. And we know that currently people are dying and we still don't know if we have COVID or not because we still don't have adequate testing. And even the tests that we have, they have flaws in which we have a high false negative rate, which we can talk about later. But it basically means that someone tests, and even though they're infected, the test says that they're not. And so there's many things that are complicating our ability to truly put our finger on the pulse of the influence of COVID-19 in America.
Well, I know we've heard stories out of Colorado that many people died and were buried without receiving tests, and before they even identified what the cause of death was. I know I've had a friend who passed away suddenly here, and we don't know if those, because the lack of availability of tests, they were saving them for other purposes and were not administering them to people who had died. Now, you talked about a term that's very familiar to me, but I don't know that it's familiar to everyone, and that is a food desert. Here in the state of California, we have both some of the richest counties in the world and the poorest at the same time. We also have a Central Valley that is home. It has the highest poverty rate in the nation. It also is the center of agriculture for the nation. It has no sidewalks. It has no grocery stores. It has tremendously high levels of pollution and illness. And so we're wondering, I haven't gotten a report out of the Central Valley. I mean, it's all that I can do as an elected official just to figure out what's going in my own county because of the problems with testing and the reliability of data. So it's clear that it's going to take us a long time to sort out just how broad an effect it's had. But I know you're talking about seeing numbers of 1 in 3,000 Hispanic people have passed away. Is that nationwide?
Nationwide.
Okay.
Now, as far as Orange County, I'm not sure if, so with Orange County, you guys are doing pretty well. And California, may I say, has done a fantastic job. I mean, you're the #1 populated state in the United States. You carry the 4th largest number of cases nationwide. But if you look at that in sheer numbers based on population size, though, you're ranked, I think, 33rd out of the state. So that's fantastic.
And we shut down early. But right. Here's my problem understanding the data.
Right.
We know that there was an outbreak in a nursing home, and we know that at the time before the entire population was tested. Now, and we heard this through the union NUHW. So we had first heard that there were only 2 patients who had COVID-19, but there were 19 workers who ended up testing positive. So when they tested the entire facility, it came out that 42% of the patients were positive for COVID-19. Now, trying to figure out where those cases were even reported, because they're going to be reported in their residence. And so I know when I've had a family member in assisted living, that is not their residential address because you're going to get their mail and everything somewhere else where they're monitored. So we had an issue trying to track where are those cases even being reported? Are they being reported? And so trying to get our arms around that data. We in Orange County have a substantial Asian American population that are frontline workers, healthcare workers, and nurses. And we're concerned, of course, about the effects on our entire population. Now, and we happen to have a very small African American population in Orange County, but growing. Right. And so I haven't been able to see any impact of the data in our county. For example, the city of Irvine has 285,000 residents, but Monday through Friday, we have 600,000 workers. So right. If you get sick in our city, are you a grocery employee or an Uber driver or an essential frontline worker, where are you reporting that illness? Completely. And so maybe you could help us understand. I know we talked about tracking, tracing, and treatment. And if you did that maybe in the context of availability of services to people of color and the community in general.
Right. So you mentioned the 3 T's is what I call them to kind of keep it in everyone's mind. The things that we need before we can fully even attempt to say we have a handle on COVID-19 would be the testing of individuals, the tracing of people if they are indeed positive, and then the treatment. And the treatment includes abilities for someone to truly isolate themselves, right? What we know is that with those who are challenged economically, you don't have the luxury of having a 3-bedroom place of where you can say, okay, I'm going to isolate myself here and the remainder of the persons can stay in other places. We know that there's an ability, if you are in those tight quarters, for everyone in the home to be exposed. And that's kind of what we're seeing now. What your question about the reporting, this is a problem that's not only happening in your county. We studied that was recently in the reports for Florida coming under great scrutiny for our data manipulation. Georgia, the same thing with data manipulation and whether or not tests are being reported. The problem that I feel we truly have is that with the administration, initially, let me back up. The World Health Organization had a test that was available that over 60 countries immediately in January started to use the World Health Organization's test to begin this rapid testing. And that's why South Korea, very early on, they were testing 10,000 people a day and still to this day are able to keep their number of cases and resulting mortality to a relatively good number. I say relatively because any one loss of life is a huge thing. But in the United States, Donald Trump decided to not use that test. And so that delayed us by about 12 to 14 weeks of ramping up our testing protocol. Now, the reasons for that was to privatize, to take and allow private companies to present tests in order to detect COVID-19. Now, usually there's a standard way to validate these tests, and you have to go through the FDA to prove that this test that I'm saying is able to detect this virus is true, and it holds standard across many different samples. Well, in an emergency situation, you can get clearance, and it's called the EUA. And so the FDA said, we know we're in a pandemic. We have to get these tests out pretty quickly in order to better protect our patient population or our citizens. And so what resulted from that is that we have a number of different tests that haven't been validated to a certain standard. And for instance, the test that Donald Trump had on his press conference, I'm sure you remember the big box, that was called the Abbott Now, and they touted they can give you results between 5 to 15 minutes of whether or not you have COVID-19. Well, what we found these last few weeks is that the false negative rate for that is about 48%, meaning that for every 2 people that I test, one of those persons, or if they come back both negative, one of those 2 people, I told them they were negative, but they're actually positive. And so the ability to truly, when we're talking about the testing and tracing part, if that person was falsely told that they were, completely free of the virus, I'm not able to trace them now within the community they go back into. And so that makes it difficult. We know that what also makes it difficult for tracing is, just like you said, is that many of the essential workers, they don't necessarily live in the same city or in the same location of which they work, whether that's cost of living, right? And there's many different things that play into that, because now you have to think about transportation and whether or not they're using public transportation, which I'm not sure if that is, it's definitely not a problem in Charlottesville, Virginia. We don't have massive transportation.
Same here. We have
Right.
we have very limited massive transit.
Right. But it's a huge problem when you're thinking about cities like Atlanta and you're thinking about cities like New York City, right? But the same still persists, though, of this massive influx of people in and out of the city. And how do you control for that? And so it is where we're going to have to really lean very, very heavy, because of those two factors, on the third T, which is going to be the treatment option of, once we know that there is something there, that someone is positive, if they're not sick enough that they need hospitalization, then how can we make sure we give resources to those persons so they can take care of their family and remain at home? And then also the treatment end of, what can we do once you're in the hospital? Do we have medications that are readily available to help you hopefully weather the storm? How are we in terms of vaccination? We know it takes years before you can get to herd immunity. So to even think that that can be a quick pull, it's just not there for us. So it really does make you start to think that our normal will have to now be shifted, and it'll be a new normal for at least a year or two, I think.
I wanted to talk about two other things. Now, you used the term storm, and it made me think of the cytokine storm, and I'd love to have you explain that. And then I was going to ask you a question about comorbidities. So before we get into the comorbidities, could you tell us, because a lot of people have been saying, and even our own board of supervisors, that the people who have passed away were very ill and they were going to pass away soon anyway. And so, for example, when they announced that there were 14 deaths in one day in our city, and they said, well, 10 of those people came from, a licensed care facility, like as if that meant that they were on the,
right,
close to dying anyway. So can you explain a little bit about that and the cytokine storm, which we've seen?
Right. So as far as the, I think a couple of the biggest mistakes we made as a nation early on was try to define what COVID-19 meant for people and who it actually targeted. Because early on we said that kids were okay, and now we're seeing that that's not totally true. Early on we said this was a elderly population disease, and we know that's also not true. We also said that you had to be pretty much sick and or dying before you can actually have mortality associated with COVID-19, and we know that's not true. In my ICU, we have we had at a week or so ago, well, let me just say this. We had some very young people, and when I say young, I mean younger than me, that were on life support. And what I mean by life support, I mean is an ECMO machine. So ECMO is it's a heart-lung machine. So it's equivalent to if you're going to have heart surgery, how we would put you on bypass. It's a similar type process that we use in the ICU that allows for your heart to completely rest and your lungs to completely rest. And even with that modality of saying, if your lungs aren't working, don't worry about it. We'll pump oxygen into your blood. If your heart's not working, don't worry about it. We will literally push blood throughout your body. Even with that measure of support, of which we have nothing that's greater, we still had deaths. And these people, again, were younger than me. And so, and young, and not only younger than me, but young and healthy as well, no comorbidities. And what we're seeing, even with our children, for instance, we're now seeing in at least 14 states, we have 100 cases of this post-inflammatory syndrome. So basically, It kind of resembles Kawasaki, which I think some people may have heard prior to, which is just a basically inflammation along the vascular tree. And so with these children in particular, we're seeing it has an impact on the arteries that supply blood to the heart. And the question is, what does that do for the child, for the longevity of life? The average age of those patients or those kids that we're seeing is 11 years old. And so this isn't something that coronavirus, this COVID-19, it is so new to us. To try to put a label on it within 7-8 weeks is dangerous. And I think the reason why we saw such a massive spread is that when we told people it only impacts you if you're old and it only impacts you if you're sick, then that gave the college students free rein on spring break because they're neither old nor sick. And they soon became vectors that spread this like wildfire across the entire nation. And so as we're going into this second phase of opening up the economy and restarting things as normal, we'll now see where in January we had 100 or so vectors scattered throughout the United States in New York City, California, and Washington. Now we have vectors literally in every zip code of every city, of every county, of every state. And so your likelihood of being exposed to this, if you're not careful and not protecting yourself, goes up exponentially.
Well, thank you. And I'd like to address the comorbidities because I think that goes right to the topic of what we're talking about. Now, comorbidity means that you have something else that's wrong with you, right? And so we, in my area, see an extremely elevated rate of cancer in the Korean community. Mm-hmm. We see that because they also have a very high level of entrepreneurship. So they're their own business owners, which often means that they don't have either comprehensive health care or very limited health care. And so typically they won't get screened for cancer, and they have a very high death rate. And it comes directly from lack of early care or regular health care. Mm-hmm. So comorbidity is something that means maybe you have diabetes, maybe you're obese, maybe you have asthma, or maybe you have maybe Hep C that's untreated. Mm-hmm. Could you walk us through why that has a correlation with COVID and why that has a correlation with race?
Right. So as far as the race, that can be pretty easily tied into the fact, again, like we talked about the social determinants of health. You can't talk about cancers, for instance, without talking about pollution. We know that what we put into our mouth as far as our nutrition plays a huge role in that. We know that toxins as far as in the air and air quality plays a huge role. Even stress itself, most time people think, oh, I'm just stressed out, that's no problem. No, stress, we know it's directly linked to whether or not you will develop cancer, whether or not you will develop chronic illnesses like hypertension and diabetes, because it's an activation of your hormone system. And what do I mean by that? If someone jumps out and scares you, automatically your heart rate goes up, right? Your breathing pattern changes, your blood pressure shoots up because it's an activation of your adrenal axis. So if you're living in a time like we know in the news right now, you see as far as the African American community, there's a great sorrow for what has happened to George Floyd, and the killing at the hands of the police officer. Seeing that constantly, day to day, week to week, the constant adrenaline surge that you get and how that plays into the development of hypertension and heart disease and heart failure, it's a natural response. We were supposed to only have those surges if we had to run away from danger, right? Prehistoric caveman time. But now that we don't have to run away from that type of danger, now we're seeing it on TV and you don't turn it off, and it's a constant. So that's why I tell people definitely kind of protecting of energies. So, but to get to, so that's why we know certain comorbidities are likely to form based on the food.
From the environment.
From the environment, literally policies, the way policies are formed to determine, even if when you're talking about health insurance, we know if I have the choice between feeding my family or getting health insurance, I'm going to feed my family first, right? So we know wealth has a play into whether or not you're going to have health insurance. And so you have to think about then which communities have the best educational system, because with educational attainment, the hope is, and we know there's still a gap in there too, but the hope is with educational attainment, you'll be able to accumulate a certain amount of wealth and will allow you to afford certain resources such as health insurance. So, so how that plays into it. Now, but to get to your question about how does comorbidities tie into deaths with COVID-19, the way I like to explain it to my families when they come into the ICU is that if for 60 years, let's say you have high blood pressure, high cholesterol, diabetes, and kidney insult, but not kidney failure. So for the last 60 years, so for 6 decades, your kidneys have already been on this treadmill of where they're running at 80%, just trying to keep up and maintain and keep you off of dialysis, right? And then you come in and now you have COVID-19 and boom, right? COVID-19 causes a cytokine storm, as you spoke of, and cytokine is just literally your immune response to say something is inside of me that shouldn't be here, and now I'm in a fight or flight situation, and my immune system is in an uproar. So we tell those kidneys that have been running for 6 decades, we say, we know you've been running at 80%, but now I need you to step it up a notch, and I need you to go into a full sprint, right?